The next talk is by Dr. ASHISH JAIN on intravitreal antibiotics, when and what. He has done his VR fellowship from Grant Medical College and is now doing VR private practice.
Good morning, everyone. So I'll be giving on a talk on intravitreal injections. So first thing we see an end off in private practice is what has happened. But keep calm and difficult to have a smile, but try that. And moving ahead, early diagnosis, a good history and appropriate management will give you a very good outcome with the current management protocols that we have. So intravitreal injections for end off, we have multiple things we have to keep in mind. First is which is the ideal choice, which is the choice of combination that you're going to use. Are you going to use steroids or not? The dosage, the dilution, and then the actual execution. So intravitreal drug administration was started right back in 1944 by von Salman and colleagues. He had injected penicillin in end off and he got a very good result. Effective concentration of antibiotics was achieved in the vitreous cavity. So when injected early, prior to irreversible destruction of retina, it is most useful. Now, which is the ideal antibiotic for intravitreal injection, which is effective against the offending organisms? It is non-toxic to the retina and the other structures, has appropriate half-life and easily available, and last but the best thing is it has to be cost effective also. So the most common choice of antibiotics that we use, most common infections is for gram-positive organisms. Vancomycin becomes the first choice of antibiotic, and for coverage of gram-negative organisms, we use mainly ceftazidime. Aminoglycosides are a very good antibiotic against gram negative, but because of the retinal toxicity, we don't use it more commonly. So the most common choice of antibiotics becomes vancomycin plus ceftazidime. With newer antibiotics like imipenem, meropenem, and colistin, we have increased our coverage of organisms, but this still forms the first line of management. Modification can be done according to the culture report. Once the organism has come and is not responding to the routine antibiotics, then we can change the antibiotic according to the clinical response. If after the first intravitreal you're not getting the sufficient response, then you can change. A repeat intravitreal injection should be done ideally after 48 hours of the first injection, and if the repeat culture is positive, and single antibiotic depending upon the sensitivity patterns. Usually after two intravitreal antibiotics and not sufficient response, you should move ahead with a vitrectomy rather than going for the third intravitreal injection. Intravitreal corticosteroid, it helps in reducing the inflammation, reducing the toxic endotoxins of the offending organisms, and helps in increasing the outcome and a good visual outcome. So it is to be avoided in fungal etiology because it will increase the pathology more than helping us. And definitely, if there is not a doubt of fungal, then you should avoid. Otherwise, always steroid should be used. It is definitely helpful in giving intravitreal corticosteroids. Coming to the dosage and preparation, the most commonly used vancomycin. It comes in 500 mg and 1 gram. So depending upon the dose of the vial, you have to choose. Inject 5 ml of distilled water, take 0.1 ml, dilute it with 0.9 distilled water, and give 0.1 ml of the antibiotic. This forms 1 mg of vancomycin in 0.1 ml. The second is ceftazidime. It comes in 250 milligram vial powder. We take 5 ml. The same protocol is followed, 0.1 and diluted to 0.2, and this gives around 2.5 mg. The dose is 2.25, but we give around 2.5 mg in 0.1 ml. And this can be also diluted with decadron, that is dexamethasone, so that we also give 400 microgram of dexa along with ceftazidime. Amikacin can also be used, but generally not preferred over ceftazidime. And amphob is to be used when we are suspecting a fungal pathology. So amphob comes in a 50 milligram powder form. You dilute it with 10 ml of distilled water and then take 0.1 ml and dilute it twice with 0.9 ml of distilled water to get the desired concentration. So this is how the trolley should look like. The antibiotic of choice, we have two antibiotics. You should keep sufficient antibiotic around 1.5 to 2 ml, because while changing the needle to a 30 gauge needle, the hub will take away some 0.5 ml of the antibiotic. So make sure you have around 2 ml of sufficient antibiotic and then change the needle so that 0.1 ml is left. And 1 ml syringe for the AC tap along with few cotton buds and a caliper. So the administration technique is simple. A sterile environment is used with a lot of paracaine, topical anesthetics to be used. You can do a AC tap first, or you can do a first intravitreal antibiotic and then take a AC tap. after the pressure is raised. Going with the inferotemporal area around 3.5 mm behind the limbus, and given in the mid-vitreous cavity, the bevel should be facing away from the macula, inject drop by drop. And we can also use the same needle for injecting multiple antibiotics, although if we are using Vanco and Septa, there are chances of precipitation, so preferably over different sites we can inject. So this is a video where we can see the caliper being marked at 3.5 mm behind the limbus, and then moving with a 30 gauge needle, we take it at the directly a stab incision. You have to stabilize the injection with one hand, and with the other hand you can just push the pistol to inject 0.1 ml of the antibiotic. This is the AC tap that we see. So after the injection, we just have to take 1 ml syringe with a 30 gauge needle or a 26 gauge needle, and then go obliquely into the cornea and gently aspirate around 0.1 ml of fluid, and make sure the AC will flatten out, but it's still formed. So this is the AC tap that we are doing. The second mode of collecting a sample also is a vitreous biopsy, although that should be not done routinely and should be combined only when we are doing a vitrectomy, and should be done along with a cutter. So as you see here, we have the cutter in the right hand along with a 2 ml syringe which is connected to the aspiration port. So once you go in initially without starting the infusion, just press the foot pedal, aspirate some vitreous and take the sample out. So according to the clinical response, the improvement should start within the first 24 hours and maximum within the first 48 hours. You will see a decreased AC reaction, decreased corneal edema, a resolved hypopyon, decrease in the vitreous exudates also, and the most important is improvement in the vision. So repeat intravitreal in 48 hours if there is no clinical response, and if microbiology, if the gram stain or KOH is showing you any particular organism, then go with that. Or if you feel that there is no response. Drug toxicity, as I told you, macular ischemia is seen with aminoglycosides, so should be avoided. Fungal endophthalmitis doesn't have a very good overall prognosis, and antifungal agents should be used carefully. Amphobi and voriconazole are the most commonly used antibiotics. Multi-drug resistant microbes have recently emerged, and we are seeing a lot of microbes which are very much resistant to almost all the available antibiotics. One similar case report presented by Dr. Preetham Sawant showed it being sensitive to colistin and gave beautiful outcomes with colistin intravitreal antibiotics. So customized intravitreal cocktail has to be given for each patient depending upon the culture report and microbiology report. Thank you.